بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Ladies and gentlemen, dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. First of all, I would like to welcome you back again here in this scientific event where we are going to shed light on a very important topic, not only related to primary care, but also related to those people or those healthcare providers that provide care to diabetic patients with a special focus on diabetic kidney disease. So today we are going to shed lights on diabetic kidney disease management, and we will try to connect the evidence-based and the guidelines, and we'll put the guidelines on the reality of the real-world practice. I would like to introduce myself. I'm Dr. Ashraf Amir. I'm a consultant family medicine in the International Medical Center. I'm the Vice President of the Saudi Society for Family and Community Medicine. I would like to remind you that this event is accredited by the Saudi Commission for Health Specialty for 3 hours. And this event is under the partnership of the Saudi Society for Family and Community Medicine and the collaborations with by our company, and organized by Texas ملتقى الخبرات لتنظيم المعارض والمؤتمرات. In fact, we have been privileged today, ladies and gentlemen, to have one of the prominent, eminent speakers in the field of nephrology, Dr. Sultan Al-Dalbahi, and I'm sure that he's going to add a real value, and he will enrich our gathering with a lot of insight from the specialty of nephrology that will enhance all of us as a primary care physician to be in a position to handle this kind of challenge of having a patient with diabetes and with a diabetic kidney disease as well. I would like to remind you, ladies and gentlemen, that we will have only one session that will last about 45 minutes and will be ending, inshallah, at 11:30 tonight. And I would like to remind you that you can put your question and answer in the Q&A box, and I'll be able, as a moderator, to look into the questions and forward it to our guest speakers. So without any further ado, I would like to shed the light and set up the stage by saying a statement that diabetes is still an emergency. As you know, diabetes is still a global emergency problem, sweeping the world and even the Kingdom of Saudi Arabia. We have more than 25% of our patients with diabetes. They are patients who are receiving treatment. And unfortunately, globally and even locally, we did not secure the best interests of patients, and still we are lagging behind to secure the proper hemoglobin A1C achievement target. And that's why many of our patients are subjected to the complication of diabetes, not only retinopathy and neuropathy, but also nephropathy, and this is the specialty that we are going to highlight tonight. So I would like just to give you a glimpse about the burden of the chronic kidney disease in type 2 diabetes, with a special focus in the kingdom. As you know, the diabetic kidney disease is a high global burden. And as we know that globally in 2019, we had more than 463 million people with diabetes, which constitute about almost 10% of the global populations. But again, those people with type 2 diabetes, there are more than 416 million. And if you just look into the chronic kidney disease, which affects almost 160 million across the globe, and this was the estimation of 2019. So we have 2 patients affected with chronic kidney disease in 5 patients with type 2 diabetes. And this is in fact a very high prevalence. So if we just look into this type of study, which was done by Dr. Abdullah Nasser, this is the prevalence of chronic kidney disease in patients with diabetes mellitus in Middle East. And what was the conclusion? The conclusion was the prevalence was as high as 28.9%. And the conclusion was that diabetic kidney disease in patients with diabetes is a very high prevalent in the Middle East region, with a special focus in certain parts within the Middle East. And that's why we mandate and we call for action to have a further epidemiological studies to let us know exactly how big is the problem. And if we just look into the chronic kidney disease, which affect the patient lifespan, if we look into the male, those patients with a chronic kidney disease, they have 5.7 years lost of their life. If they are diabetic, they have 10 years. But look into the deadly combinations where we have chronic kidney disease with a type 2 diabetes, they lose almost 15 years of their life. And the chronic kidney disease approximately enhance the mortality and morbidity in patients with type 2 diabetes. So we can see the mortality and goes as high as 20% in patients with diabetic and kidney disease. So the patient with chronic kidney disease, hospitalization is usually increased as long as the reductions or the diminish in the EFGR, and also when the UACR enhanced, this causes hospitalizations and heart failure and cardiovascular death. So there was association between all the things. We always focus on diabetes, but actually there is a stage before diabetes called a pre-diabetic state, where is the hemoglobin A1C between 5.7 to 6.4. And there's a compelling evidence that even this early stage of diabetes is also associated with nephropathy. So about 17% of the individual with impaired fasting glucose, they have a chronic kidney disease. So this will alert us, in fact, that there is something beyond diabetes that we have to look into even at the early stage, and this is the prevention when it comes to action. So also the reason for hospitalization in patients with type 2 diabetes with usually end-stage renal disease is always associated with this kind of enhancement of hospitalizations. So diabetic patients, they always 6 to 12 folds are likely to be hospitalized for chronic kidney disease. So this will tell us how much is the burden of the conditions on the healthcare system. And we have learned from the landmark study of diabetes, the United Kingdom's diabetes study, which showed 1% reductions of A1C will always associated with a 37% reduction of the microvascular complications in terms of retinopathy, neuropathy, and microalbuminuria. And this is very important for us to enhance our capacity and to allocate all the resources to achieve that end by safeguarding the patient from these kind of complications. So if we just would like to know the knowledge and the chronic kidney disease among the population, the Kingdom of Saudi Arabia, so this has a flavor of the local national study, which was a cross-sectional study. And the conclusion was that there was a very obvious lack of awareness among the Saudi population regarding the knowledge of the chronic kidney disease. So that's why we have to enhance our capacity to educate our patients about this problem. The care gap, which is existing, again, it's not only we are lacking behind the low testing of A1C, but also the urine protein testing did not achieve the target goal, and ultimately we are lagging behind. Despite of the treatment, the renoprotective therapies in the real world is not perceived. So we can see here, very few patients with type 2 diabetes receive drugs that decrease kidney outcome. For example, 3% of the patients, they receive SGLT2 inhibitor. So there's a high need for screening, for awareness, and for the management. And if you look in the problem globally, there are three domains that we have to think about to establish the real solutions for this problem. One is the patient factor. So we have to educate the patient about the nature of the disease, to convert the patient into an active partner and patient who can understand the problem is the issue of his role, and ultimately interact with the physicians in a very active partnership. And then we have to look into the physician part where we demonstrate a clinical inertia. We are reluctant to start certain medication to patients. And even with start, we never go up titrate on timely manner. And even we don't achieve the target goal according to the guidelines. And this is where we land our patients into the complication. And then the third domain is the healthcare system, where we have to enhance our system and allocate all the resources to bring the patient and the doctor in a proper encounter that have a successful outcome. And so the local opportunity to improve the chronic kidney disease diagnosis and management locally, the chronic kidney disease need to be recognized as a public health priority, not only from healthcare decision makers, but also from physicians and even patients. And that's why we have to demonstrate the clinical outcome that reach up to that end. Implementation of evidence-based strategy to reduce the disease progressions. So putting guidelines into real-world practice, and this is what we are going to be highlighted today by Dr. Sultan. Investment in primary care to reduce the total health cost. So nowadays we are talking about the value-based healthcare. We provide a high quality of patient care in a patient-centric approach, in a multidisciplinary team, governed by a clinical guidelines, but ultimately it has an outcome in a very cost-effective way. So this is exactly what we are looking for as we practice the real model of our healthcare system in the kingdom. So effective preventions and measures, early detection. So we are moving from intervention to prevention, from disease to health, from illness to wellness. So we have to put prevention into action. So I would like just to conclude my introductory statement by saying the chronic kidney disease is one of the most prevalent complications associated with type 2 diabetes and remain undiagnosed, untreated, and unfortunately, recommended chronic kidney disease testing is underutilized. It is the leading cause of end-stage renal disease and even kidney transplantations. And the chronic kidney disease occurs in conjunction with cardiovascular disease, as we have seen. So it predisposes the patient for mortality and morbidity of chronic cardiovascular disease. Early detections of kidney failure facilitate the proper diagnosis and treatment. So the early we intervene, the proper end result that we achieve. So the ADA 2020 guidelines recommended screening for kidney dysfunctions in patients with type 2 diabetes at least annually, assess urine albumin and EFGR for all patients with type 2 diabetes. With this, I would like just to end my introductory presentation, and I would like to introduce my guest speaker, Dr. Sultan Al-Dalbahi. Dr. Sultan Al-Dalbahi is a consultant nephrologist, director of nephrology and kidney transplantation at Prince Sultan Military Medical City. He's a chairman of the Scientific Council for Nephrology in the Saudi Commission for Health Specialty. So he's going to shed a light today on diabetic kidney disease management, connecting the evidence to the practice. So I would like, on behalf of all the audience, I would like to welcome you here, Dr. Sultan, for accepting our invitation and to be part of this successful and wonderful gathering. I will just leave the floor for you, please.
Hey, thank you so much, Prof. Ashraf, for the great introductions, and you are making my presentation more easier. Uh, uh, Based on what you present to us, really, it's very fantastic introductions. Thank you so much for the invitations. Thank you so much for Bayer of sponsoring this event, and thank you for their excellent efforts, for improving and promoting, the educations and the awareness about diabetic kidney disease. And thank you for Multaq Al Khibrat for their great organization as usual. So, in connection to what you mentioned, Dr. Ashraf, I think we are dealing here with the most common prevalent chronic disease, and the most leading the cause of end stage kidney disease. And whatever we learned tonight, and whatever we spend from effort, it's very worthwhile and valuable for any institute, to hold this disease down, and slow the progressions, and reduce the number of reaching the dialysis and end stage kidney disease. So my aim in the presentations here is connecting the evidence to the practice, just aligned to what you mentioned, Dr. Ashraf. So I don't have any things to disclose tonight. And my objective to understand the unmet need of screening of diabetic kidney disease, and describing the residual risk despite the standard of care, and understanding, the progression of the evidence-based therapeutics in treating diabetic kidney disease. Then I'll try to assess over trials what is the cardiorenal risk reductions we get so far from the evidence, and the safety profile of the MRAs and the emerging drugs. Then after that, just to give some like practical considerations, how to use the new MRAs, and what is the favorable populations among the diabetic kidney disease. So moving forward, the diagnosis of diabetic kidney disease, it depends on the GFR and albuminuria, because the GFR is index of the function, and the albuminuria is the marker of damage. And I think albuminuria, as you said, Dr. Ashraf, it's very underutilized in the practice. I'll see you some data about the France, UK, and the United States. In the best structures program, it's underutilized. So I think we are missing a lot of diabetic kidney disease, because if we are not, and the globally, we are not screening patient enough. So the diagnosis of diabetic kidney disease, when you have a GFR less than 60 ml per minute, and albuminuria is more than 30 milligram per gram, persisting in 2 occasions over the 3 month, either one or both, and most of the time we are having both. So the fantasy and the bad things in the albuminuria, it's underutilized, but it's well correlated with the mortality and cardiovascular, and it started earlier, years even, before the GFR drop. Because if we are waiting for by screening creatinine and measuring the creatinine to define the diabetic kidney disease, I think we are missing a lot of patients over years, and they might get benefit by detecting them earlier and interfering earlier. So uh, diabetic, albuminuria, it is the best marker. We should target it in aiming of diagnosing the diabetic kidney disease and treating the diabetic kidney disease. You can see here in the Europe, it's almost like 57% of the healthcare practitioners in any sectors, they are doing albuminuria. So more, almost like 40%, or half of the patient not measured, and half of the doctors not requesting for albumin creatinine ratio in a patient who's diabetic for years. So it's very suboptimal. Let me just take one example, or like a case studies, and looking for that studies. This is a 66-year-old diabetic kidney disease type 2, and for 4 years by diagnosis. We don't know. I think it's longer than that, the durations. It's detected, at the time, and hemoglobin A1C was 7.5. The blood pressure is well controlled. It's overweight. And GFR is 42, albumin creatinine ratio 400 milligram, and the serum potassium normal, no signs of heart failure, LDL is quite controlled, and patient on atorvastatin. Patient on the maximum AC inhibitor for a while, and he's receiving the standard of care in terms of insulin, in terms of the other anti-glycemia targeting medications. So, by looking to this, the vital signs is quite stable. Looking to the markers, he's very, very, moderate to severe and high risk of progressions if we look for the albuminuria and estimated GFR. So the hemoglobin 1C and blood pressures and the vitals generally, they are not good correlators or factors we should depend on looking for the stability. So how are we treating this patient? Even this patient on the standard of care and tolerating the maximum RAS blockade, which is the evidence-based drug driven the treatment of diabetic kidney disease for 4 years. So we will answer these questions over the coming slides. So as you can see, the 20 years back, from 1993 to till 2010, there is no much trial looking for the diabetic kidney disease or the new treatment of diabetic kidney disease. We depend on the RAS blockade. And there is a 3 main trials showing like evidence-based risk reductions and proteinuria reductions by using those drugs, until we start to have, in 2013 or 2015, the EMBARG, when the SGLT2 come into practice, and the scientists recognize the SGLT2 receptors. After that, over the last 7 years, you can see like a lot of trials, almost like 30 RCTs, well structured and designed studies looking for different, mechanism of treating diabetic kidney disease. We will try to look for some of these drugs showed, the best evidence in treating diabetic kidney disease. So for the audience, what is how the diabetic or type 2 diabetes hit the kidney? There's a 3 parameters. One is the hemodynamics, and we recognize that one over the last 20 years, and we targeting that one by RAS blockade. However, the end products of the hyperglycemia circulating and deposit in the mesangial and affecting the podocyte and causing a lot of disturbances in the kidney. We are targeting that one by the insulin, by the anti-glycemia control and treatment. However, recently people, they recognize in biopsy based on and clinical based in the investigational level, there's inflammation and fibrosis in the other part of the kidney, and this is definitely will driven the CKD progressions. Now, as I said, there is drug targeting hemodynamic and metabolic, but what about the inflammation and fibrosis? Why we should target inflammation and fibrosis? If you can see that the RAS blockade treating, the diabetic kidney disease for the last 20 years, there is 16% risk reductions in the cardiovascular, renovascular, and proteinuria. However, the gray area under the diaphragm is still residual risk of progressions in the stage and death. So by adding SGLT2, DABA, CKD, the best evidence available, there is additional risk reductions like 64 risk, 36, 26 risk reductions. However, there is still a gray area under the diaphragm. So there is a risk, there is a residual risk even with the standard of the care. I think this is driven by the fibrosis and inflammation. The GLP-1, with the best studies, it caused the risk reductions in the cardiovascular, renovascular, and proteinuria. However, there is a 23% of the patient having a residual kidney, a residual risk of a progression and end stage and death. So we should target the inflammations and fibrosis by anti-inflammation and fibrosis. So that's why the MRA, it comes up to the practice. So the MRA, which is the non-steroidal anti-inflammatories called phenylenone, in compared to the MRA, the spironolactone, which is the non-selective, phenylenone is selective, has a little effect on the blood pressures and the electrolyte and less, sexual side effect like gynecomastia, and less effect on the hyperglycemia. This is because of the highly selectivity of the finerenone, and this is the beauty of the finerenone when you say in the practice. It's not the end. Like if we can see in 2022 and 2020 and 2022. This is the fastest, revisions of the guidelines worldwide, and the critical guidelines, the nephrology, guidelines. So ACE inhibitor is still there. SGL2 is still recommended. And even, in 2022, after the IMBA kidney trial, we are targeting even lower and more advanced diabetic kidney disease with GFR 20. MRA wasn't in 2020, but now in 22, it's 2A, one of the high level of the evidence and targeting, and can be used, in a patient who have a moderate to severe degree or type of diabetic kidney disease. Metformin is still there, and GLP-1 and DDP4 still giving adjuvant and additional effect and benefit to the other anti-glycemia medications. In the different guidelines, other than the critical guidelines in American Heart Associations and American Diabetic Associations, from cardiovascular, from CKD point of view, they recommend using finerenone when we are unable to use SGL2, or even in a high-risk patient who an SGL2. And we will come about using them with SGL2 or not. Okay, moving to the evidence, what we have in the literatures regarding the MRA or finerenone, we have the Fidelio, started in 2015 and ended in 2018, looking to the effect of the finerenone on chronic kidney disease type 2. Then the same investigator, they look at the in Figaro to the cardiovascular as well. So they have the cardiorenal data from these things. However, they look for the pooled analysis of these, both trials or both included patient, and they analyze them to look for more potent, evidence and data regarding that one. So this is the largest, studied among diabetic kidney disease patient after the UK diabetic registry. This is the 13,000 patient, 500 in Fidelio, and 5,000 in Fidelio, and 7,000 in Figaro, and as composite, it's almost 13,000 patients. So Fidelio, it is a trial started in September 2015 and end very early in 2018 because of the enough effect. It's match, and reach, the primary outcome with very, very minimum and very undetectable like safety profile or safety issues. If you look at that one, there's a 13 patient among 48 countries, 5,000 patients with CKD. Definition was like albumin creatinine ratio more than 30 and less than 300, and GFR 25 to 60, and or diabetic kidney disease with whatever albumin creatinine ratio and GFR. If we look in the right, cartoon here, you can see like very, very excellent and comparable both arm, the finerenone arm and placebo, very equal and very highly selected populations with moderate risk, to predict and prevent, the severe risk or the higher risk. All of the patients should be a RAS blockade. This is very important when we come in the practical considerations a minute. At least 1 month to 4 months in one of the ACE inhibitor RAS blockade, and they randomized to the finerenone 10 milligram according to the GFR, or 20 milligram when we have very mild diabetic kidney disease. They follow them in 2.6 years. It's very, let's say, very enough durations to look for the cardiovascular benefit actually. Which kind of patient? The beauty here, it's different kind of patient. So it is well distributed among the degree of diabetic kidney disease. So we have a mild, we have advanced proteinuria, we have advanced, low GFR, and we have, most of the patient or the bulk of the patient, from each group, like proteinuric and lower GFR. They are excluding all of uncontrolled cardiovascular patients. Heart failure, hemoglobin A1C more than 12%, uncontrolled blood pressures, and an advanced CKD or hyperkalemic. So we have a very excellent selected patient. So we can estimate, the effect of the finerenone on them. So the beauty in the baseline, the GFR is 44, so it's not advanced much, and it's not that early much, and they have a proteinuria less than 1 gram. It's like 852. 99% RAS blockade tolerating that one and will adhere to that one. So the follow-up was 2.6. So what they are looking for, the primary endpoint was the kidney-specific composite, like time to becoming in the stage and requiring dialysis, or any sustained drop in the GFR more than 40%, or any death due to the renal cause. The cardiovascular, they're looking for non-fatal MI, cardiovascular death, or hospitalizations due to heart failure. And this is, it should be, one of the secondary output if the 50% of change in the GFR from the baseline, or doubling of the creatinine. So what they found actually over the 2.8 years, you can see the composite renal outcome. There is a risk reductions by 18% in a patient started on finerenone. And the beauty here started in the first year, and the effect becoming bigger and bigger and more benefit till we reach the end of the study. So it is very earlier and very sustained, and even getting much potent this effect, when the patient become for 2.5 years on finerenone. If we look for preventing any drop in the GFR more than 40%, it's almost like 19%. It's very excellent, and it's started earlier and persist or become sustained, in that part. If you look for the kidney failure, yes, there is almost like a 13% risk reductions. And all the secondary composites, from the kidney or doubling of creatinine, it's much better in patients who are receiving finerenone. If we take all the kind of the outcome together, you can see all toward and in favor of using the finerenone. Very statistically significant. The effect on proteinuria, people who are interested in treating GN and diabetes, diabetic kidney disease is considered a secondary GN. There is a very excellent remission, over 4 months, which one of the earlier effect, compared to steroid and compared to tuximab or the other, cytotoxic drug. And it has become persistent in the same dose in people using the finerenone. Very excellent outcome, actually, in terms of the reducing the proteinuria. What about the Figaro? Figaro, it's almost the same, using more mild patient with a higher proteinuria, because we are looking for the cardiovascular outcome. So we don't want to take more advanced patient, and we will see, we will find nothing actually if we are selecting the high risk patient. It started 2015 and ended in 2018 for the same reason, because the Ireland investigator, they observed the very excellent matching to the primary outcome earlier. 19 patients, 7,000 with diabetic kidney disease, the same definitions, and well distributed among the two arms of the intervention and placebo. The same things. 4 weeks, patient was on RAS blockade, a maximum dose, and well tolerated. Then they just randomized them to the same doses of the finerenone. The beauty here that 60% of the patient have a GFR more than 60, and more than 45-20%. So 80% of the patient, they have a very mild to moderate GFR and compared to the Fidelio, because we are looking for the cardiovascular outcome. So the same definitions of the primary outcome and secondary outcome. So the secondary is the kidney and the primary is the heart, with the same definitions of the outcome. They have like a 13% risk reductions of the cardiovascular MI, death, and hospitalizations. Very, very excellent. Started very earlier, even 6 months, earlier than what we found, in a patient who is on Fidelio trial. You can see very excellent for the hospitalization due to the heart failure. And I think this is one of the most important, for the cardiology, for nephrology, and for family medicine. The hospitalization is the main concern in the CQI issues. So it is reduced starting by the 6 months being on finerenone, and it's persistently. If you can see the patient who is reaching 54 months on finerenone, they are very, very low risk, to be admitted due to the heart failure and compared to the placebo. Again, all the outcome, primary and secondary, toward the using or being on the finerenone and compared to the placebo. Okay, so if we just compare what I just mentioned, Fidelio looking for the kidney or CKD progression reduced by 18%, and the cardiovascular in that one as a secondary outcome is 14%. And you can see it's very comparable in the Figaro, even in the moderate stage and advanced stage of the CKD. The cardiovascular mortality and morbidity reduced by 13%, and the progression by 13%. Guys, this means like if you have a huge dialysis unit and look after 2.5 years, you will see like 13% of diabetic kidney disease not reaching the dialysis. This is fantastic, actually, for people who have a lot of issues with slot and dialysis and having more patients due to the diabetic kidney disease. Okay, so now Fidelio putting all together, like the both pools, both type of patient, and looking for the outcome. The protocol almost the same. The follow-up just extended to 3 years, and the outcome it's almost the same. But the diabetic kidney disease, because it's a mixture of mild and moderate, they ask for more advanced drop in the GFR, like 57 or 60% drop in the GFR. So they found like the baseline, it's well distributed. Like we have a patient who have like advanced, 26 moderate, and 40% they have mild. So we have like equal distributed 3 degree of CKD. And albuminuria, it's most of the patient have proteinuria or albuminuria. So just like, the mild is 30%, but 67% of the patient have, let's say, advanced proteinuria. So they look for the hyperkalemia. It's happened very, very common in the, the discontinuation due to the hyperkalemia. It is very prominent in the placebo. In the finerenone, but it's incomparable, very mild, very small type of patient, and very treatable actually when it happens. Okay. So this is, as we said, it's a very excellent result, reducing by 20%, approaching dialysis. This is very, very important for us as a nephrologist, actually. Okay, so now I think this is for family medicine. This is the most important slides. What is the best candidate and what is the best time to consider finerenone? If we take it as a criteria, the first criterion, this type 2, it's not well studied in type 1. I know with the time it will come to the type 1, it will come for advanced dialysis and transplanted. But meanwhile, we are targeting the type 2 diabetes mellitus. It should be for 15 years, because when we diagnose type 2 by albuminuria, we consider like they are more than 5 years or 10 years already having diabetes. So the second one, they should be a CKD, either way, by albuminuria more than 30 or the GFR less than 60. We are not targeting it's not given like prophylaxis or preventing diabetic kidney disease, but it's slowing the progression of diabetic kidney disease. The third one, patient should be RAS blockade for 1 to 4 months. And this is well studied in both studies, in Figaro, Fidelity, and Fidelio. They should be at least 14 weeks. For me, I'm selecting the patient who's already in 3 months, 90 days on RAS blockade, well tolerated, and having a good blood pressures and whatever the proteinuria. They should be on the standard of care. They should be RAS blockade. They should be having good blood pressures and good glycemia control, hemoglobin A1C. So we are not using a patient who is already losing the control of hemoglobin A1C. Then after that, the patient should be hemodynamically stable, like RAS blockade. Majority of the patient, 99 of the patient studied on finerenone and RAS blockade. The other treatment, like a glycemia, most of them in insulin, some of them in GLP-1, some of them in SGLT2 inhibitors. If we come to the criteria 5, the best candidate actually, the patient who have earlier stage, like by GFR, and late albuminuria. Unless we are doing screening, we will not catch those patients. So I think we should screen our patient, and I think the weight and the rule, the big rule for the family physician doctors treating diabetic, because when you screen them and found creatinine is quietly good and albuminuria even in RAS blockade high, this is the best time to refer the patient or to start the patient on finerenone. This can be prescribed and should be prescribed by people in primary care setting. Then refer the patient to the nephrology clinic and to follow up the potassium and the other stuff. So if you can see both Fidelio and Figaro, most of the patient, or the higher number of the patient, they have a GFR more than 60 and proteinuria more than 300. Criterion 7, you should exclude any one of these populations, like significant renal artery stenosis, non-diabetic disease diagnosis. If you have a suspicion, do biopsy. Patient who have more nephrotic range proteinuria, hemoglobin A1C more than 12, uncontrolled blood pressures, uncontrolled heart failure, stroke, patient on dialysis, transplanted patient, hypersensitive, Addison due to the hemodynamical instability, hepatic failure, active malignancies, pregnancy and breastfeeding. And I think this is limited data. The safety on that one, it will become later. So after, starting the drug and launching the drug for at least 3 years. What about the other drugs? Is safe to be used for other drugs? We shouldn't use it for another non-selective MRA like clopidogrel, spironolactones, or renin inhibitors. It should be stopped like 4 weeks before starting finerenone. We can use it with ACE inhibitor and ARBs, and other drug which is potent for cytochrome B450 or 3A4 inhibitors, like antifungals, like any other medications, like grape juice. We should stop all of these 7 days before starting the MRA. Does SGLT2 matter? Should we use it before? Should we use it after? It never matter. If you look to the both trials and data, 6.7 patient thankfully was on the SGLT2. So whatever have risk reduction contributed to the finerenone, not for the SGLT2. So you can see, like, without SGLT2, there is 32 risk reductions, and it is increased to 37 mildly, when we add SGLT2. So, and if you look for the cardiovascular, heart failure, GFR, and decline in GFR, all of these in favor of using the finerenone, either with SGLT2 or even without SGLT2. So there is an ongoing study trial called Confidence. They randomized the patient diabetic to diabetes with CKD features in finerenone with empagliflozins, finerenone with the placebo, and empagliflozins alone. And they are looking for for the cardiovascular and safety profile and renovascular. Till now, the interim analysis, it showed a very excellent, safety profile. The same effect with Fidelio Figaro, and the very, very, very insignificant or statistically insignificant safety issues. So it's very safe to be used even in the same time. Now, regarding, the adverse effect, it's very comparable to the placebo. All kind of adverse effect, any serious or AKI and gynecomastia, very comparable. What about, change in the blood pressures? There is no much, very comparable to the placebo. What about the hemoglobin A1C? There is no much changes in the hemoglobin A1C. Regarding the potassium, the potassium increased by 0.23 very trivial, and it's very sustained, over the time. So it's not a cumulative cause. So treatable, very minor, and it's not a concern. So lastly, if you can see, even with some evidence, event and incidence of a hyperkalemia, nothing cause like discontinuations, nothing cause hospitalizations, and no death due to the hyperkalemia. So if a hyperkalemia happened, there is a protocol well designed and published now in the guidelines. When we start the finerenone by dosing, 10 milligram for the GFR from 25 to 60, or 20 milligram for the GFR more than 60 in a patient with type 2 diabetes and CKD, we should, and potassium should be like less than 4.8 or 5 at least. We repeat the potassium after 1 month, and we repeat it another 4 months. After the first sample, if the potassium is 4.8, after 1 month, we continue the same. 5.5, we hold for 72 hours, then we repeat the sample. The second sample, if it is more than 5, we hold it and we just monitor the potassium. If less than 5, we resume it by 10 milligram. Then we go with the GFR again to 20 milligram per second. This is what I mentioned. This is just summarizing how we monitor that one safely and even very, very, very treatable. All the guidelines, American Diabetes Associations leading the treatment of diabetes, and KDIGO leading the treatment of the CKD, they recommend in level 1A to use the finerenone when you have a patient with a high risk and you are unable to use SGL2, and patient on the maximum tolerated doses. So lastly, remember the rule of 5. Use finerenone when the potassium is 5 in type 2 diabetes and CKD and GFR more than 25. Don't stop till you have potassium 5.5. It's a very safe drug. Expect, to reduce the dialysis risk by 20% and the heart failure by 20%. And please try to start it as a GFR more than around 60, because this will mitigate the risk of the hyperkalemia. So as a conclusion, annual screening of GFR and proteinuria very crucial to diagnose and estimate the risk of diabetic kidney disease and CKD. Before starting the MRA, we should use RAS blockade for 1 to 4 months. Diabetic kidney disease patient should have good glycemia, good metabolic, good hemodynamic control, and the standard of care. The best candidate is the patient on the GFR 60 and advanced albuminuria 300. And, we are excluding all of these uncontrolled systemic disease, pregnancy, liver disease as a contraindications. And lastly, MRA initiation decision, always irrespective of SGL2. This is a very, very independent drug. I think we should introduce it to our patient. Back to you, Dr. Ashraf, and thank you so much for the audience for their attention.
Thank you so much, Dr. Sultan, for this wonderful, elegant, illustrated, very extensive, detailed presentations that I really enjoyed it piece by piece, in fact, because it has a lot of information that I think will be reflected positively on the way we practice medicine, especially for those who are in primary care and family medicine. So thank you so much on behalf of all the audience. I received a lot of comments from the audience. They are appreciating the quality of your presentation, Dr. Sultan. And now, ladies and gentlemen, I would like to move to the Q&As. We have received many, in fact, 38 questions, but I have selected some of the questions that might add, in fact, some of some of the values to the clinical practice of all of us. So the first question, Dr. Sultan, when to start screening for the chronic kidney disease, soon after diagnosis of diabetes or later on after a couple of years?
Okay, very excellent questions. Really, we want to offer utilizing, the urine diabetic albumin creatinine ratio whenever we have a type 2 diabetes. It's a very prevalent drugs. Like if I do 400 patients missing like 90 and getting 1 or 2 in those 10 patients remain, this is very worthwhile, to starting, predicting the risk and putting the patient in the drugs. The answer, I think before we believe that there is some time limits, I think now with the rising incidence and prevalence of diabetes, we should use it in the time of diagnosing diabetic kidney disease.
Absolutely. Well said, Dr. Sultan. And I have to mention here, even in the stage of pre-diabetes, there is a compelling evidence that pre-diabetes is also associated with kidney disease, with a renal impairment, as we have seen on one of the slides. So the microvascular complication of diabetes starts 5 to 7 years even before the diagnosis of diabetes. So that's why those patients, once we diagnose, they already have, their residual impairment in the renal functions. So that's why the screening as early as possible and as soon as we diagnose is very important. The other question, Dr. Sultan, what is the role of UACR play in your treatment decision? So how this will modify the way you decide for treating patients with chronic kidney disease and patients with diabetes?
Okay, absolutely. This is the main determinant in the trial. So if we are using the selecting patient for the phenylalanine, albuminuria, urine albumin creatinine ratio, the main part, and the decision-making determinant. The second one, when we monitor the effect of the drug, you need the albumin creatinine ratio. We are not depending on the GFR because we are aiming to control the albuminuria to see like in a 5 years stability of the GFR. The second one is when you look to the exclusion, it's very important because some of the nephrotic diabetic kidney disease should be excluded from the trial because nephrotic means a lot of damage, a lot of no more space to use phenylalanine, and even if you use it, will be high risk of hyperkalemia. So it's very decision based determinant.
Okay, excellent. There is a question from Dr. Najibuddin Muhammad. He asked 3 questions, but we'll take one of them or 2 of them. Do we need to do dose titrations or withholding the phenylalanine in case of hyperkalemia with potassium more than 5.5? I think this has been mentioned in your presentation.
Yeah, I mean, if it is in the when we screen in 5.5, we shouldn't use phenylalanine. If it is less than 5 and we start phenylalanine after 1 month and we found it more than 5.5, we should stop it for 72 hours. This is a highly selective drug, short acting. So we expect in 3 days all of these high the 0.23 rise in the potassium will disappear because it's not like spironolactone. There is no metabolite circulating and active in the circulations. It's highly selective, so it's very safe to use it with no monitoring unless 4 weeks, and it's very safe, when you stop to just repeat after 3 days to start titering. When we have hyperkalemia, all the published guidelines and protocol and even the Saudi FDA, they mention start with 10. Then after that, titrate up later, when the potassium is becomes stable.
Okay. The other part of the question, Dr. Sultan, for Dr. Najibuddin said, phenylalanine could be considered in non-diabetic primary kidney disease with proteinuria?
Excellent. This is
what
from
yeah.
This is what
diabetes.
Yes, this is what happened, like what happened in the SGL2. SGL2 mainly started in diabetic kidney disease. The scientists, when they analyze the data and they look for non-diabetic kidney disease like CKD, they found more potent even. I believe, the fibrosis inflammations, like what happened in diabetes, happen in FSGS, happen in IgA. I think it will be indicated in those patients, and because this is a new drug, the company and the scientists, they don't want to expose for more populations for the safety profile. When we reach 3 years with no safety issues and diabetic kidney disease, people will they start, in CKD as well.
Okay. Just to make what we have been saying more practical, because we have a lot of primary care physicians, I'm sure this questions will just reinforce the concept of which patient with chronic kidney disease and type 2 diabetes would be first selected for finerenone initiation. So this is the profile. What is the profile of the patients that he's indicated to have finerenone?
Excellent questions from family medicine physicians. As we said earlier, from GFR, later from proteinuria, and the priority for the GFR. Like if we have a patient with 60, we should, and any kind of proteinuria, we should start. We can see like there is like 30%, of the patient already with mild proteinuria. So the best time by screening people, taking a patient with creatinine of 120, 150, for example, and having some element of the proteinuria. This is the best time, actually. What we mentioned, like early GFR and late proteinuria, this is the ideal. But I think we shouldn't wait to reach that one. If we have them, yeah, this is the excellent. But in health and clinical practice, I think we should screening for GFR, then after that seeing if the proteinuria, then putting the patient on who already on RAS blockade and finerenone, regardless or respective to the SGLT2.
If we revert the same question, Dr. Sultan, and say which patient with CKD and type 2 diabetes in your clinical practice would not consider finerenone?
Excellent. This is, any extremities like advanced CKD, like GFR less than 25, patient who have nephrotic range proteinuria. This is as a CKD parameters. Then as a systemic parameters, in controlled hemodynamics, high blood pressures, heart failure, patient who have renal artery stenosis, or why we are seeing like nephrotic range proteinuria, because always there is a room to look for secondary cause or coexistent autoimmune disease or something else with the diabetic kidney disease. So those are the extremities. I think we should exclude them. And the best way to decide is just doing, in addition to the GFR, proteinuria and type 2 diabetes. And when we have any element of CKD away from this contraindications, this is the best candidate in populations. Yeah.
Okay, excellent. You said, Dr. Sultan, that finerenone can be also combined with SGLT2. So in your clinical practice, when do you choose using finerenone over SGLT2 inhibitors?
Excellent. I think, confidence trial reassuring all of us that there is no harm of adding both. But I think, if you are selecting a patient earlier and there is a room to treat them, I think the full care diabetic kidney disease, which my advice and my intention to do in my patient, because we just like approve this drug and selecting our patient, I think the best practice is making sure that the patient is on SGL2 not overactivated, and RAS blockade, and RAS blockade system is not overactivated, like the patient already on AC inhibitor for 3 months. Then after that, I'll give the priority for SGL2, like because we are not in hurry, to hold the rapid progression of diabetic kidney disease. Because we are selecting the best candidate. We should put SGL2 for another 3 months. Then we add finerenone. I think in 9 months we already block all the risk from different pathways and putting the patient in the full care diabetic kidney disease.
And when to use the combinations, the finerenone and SGLT2 to start with?
Excellent. I think if we, maybe diabetic kidney disease with cardiorenal, like with very, very preserved ejection fractions. There is a good data for SGL2 from cardiovascular point of view, and there is some receptors in myocardium and very excellent effect on regenerations of the left ventricle functions. I think in those kind of patients, we might use these both together. Or if we catching a patient who is rapidly progressing but still in the good range, like drop from 460 to 45 or to 35. Yeah, I think we can put both. Yeah.
I think we are coming to the end of the questions and Q&A session, because in fact we have a lot of questions, in fact, but somehow they are repeated questions. And I would like, on behalf of all the audience, Dr. Sultan, I would like to thank you so much for giving us this wonderful information that I'm sure everyone will carry along with us, to put it into practice tomorrow onward in our clinics, and to manage our patients with diabetic kidney disease. So, ladies and gentlemen, I would like just to conclude what has been said by Dr. Sultan. Annual screening of estimated GFR and the presence of proteinuria in type 2 diabetes is crucial. So make sure that you practice this kind of screening as an early intervention and early detections in order to promote the promotion of health and to intervene in early, to delay the complications. In fact, diabetes is a progressive disease. We cannot stop the complication. At least whatever we do is just only delaying the complication onset and improve the quality of life of patients. Before MRA's initiation in diabetic kidney disease, patients should be on RAS blockade for about 1 to 4 months, as stated by Dr. Sultan. Diabetic kidney disease patients should have a good glycemic, metabolic, and hemodynamic control while on diabetes standards of care. And we know in American Diabetic Association mandated the hemoglobin A1C to be up to the level of 7%. But again, we know that managing patients with diabetes is just only target A1C, but also to add the benefits of the cardiovascular and the renal protection type of benefits. Early chronic kidney disease, GFR 60 and late albuminuria 300 to 5,000 milligrams are features of the best diabetic kidney disease candidate for MRAs. And diabetic kidney disease patients with uncontrolled glycemic disease, pregnancy and liver disease should be contraindicated for MRAs initiation, and MRAs initiation decision always be irrespective of SGLT2 therapy in type 2 patients. And I would like also to remember the wonderful statement that's said elegantly by Dr. Sultan. I love it so much. The rule of fives, in fact. So I will memorize it and I'll keep it in my desk in my clinic. So it's stated that use very known in chronic kidney disease with type 2 diabetes if potassium is at most 5 and estimated GFR is more than 25. Don't stop till potassium reach up to 5.5 and accept fifth reductions in dialysis and more than fifth reductions in heart failure on top of the ACE inhibitors or ARBs. Key is to start when estimated GFR preserved to mitigate risk of hyperkalemia. So with this, ladies and gentlemen, I would like to thank you so much for being with us in this wonderful event. And on your behalf, I would like to thank Dr. Sultan once again. And I would like to thank Bayer Company for giving us this wonderful opportunity to be together. And I would like to thank the Saudi Society for Family and Community Medicine being partner with us. And I would like to thank all of you, ladies and gentlemen. We have more than thousands of attendees in this wonderful session. Looking forward that we meet again in the pathway of saving the life and doing the best for our patient with diabetes and patient with kidney disease. So I wish you a happy Ramadan and a wonderful night full of blessing. Until see you again. Assalamu alaikum wa rahmatullahi wa barakatuh. يعطيك العافية دكتور سلطان، شكرا جزيلا.
يعطيك العافية دكتور، إضافة كبيرة لي، الله يسعدك.
الله يعطيك العافية. إن شاء الله هذه زي ما بيقولوا الخطوة الأولى في مشوار ال1000 ميل.